but it is my honor now to introduce Dr. Perry N. Halkitis, who is it's an incredible individual. I had the honor of meeting Perry virtually in the middle of the pandemic. And after talking to him, I was incredibly relieved that we had such a innovative, committed leader in public health in New Jersey in the middle of this pandemic. And just great to get to know an individual who is so committed to issues of equity and inclusion in public health. Perry N. Halkitis is a public health psychologist, researcher, educator, and advocate. He is the Dean and Professor of Biostatistics and Urban Global Public Health at the Rutgers School of Public Health. He's the founder and director of the Center for Health, Identity, Behavior, and Prevention Studies. And for 3 decades, Dr. Halkitis' program of research has really examined the intersection between HIV, HPV, and other STDs, drug abuse, and mental health burden with regard to the biological, behavioral, psychosocial, and structural factors that predispose those and other health disparities in the LGBTQ plus population. His work focuses on the translation of the knowledge through implementation, science research that examines the effectiveness of tailored and adaptive interventions in order to prevent and eliminate these disparities. His research has been awarded over $300 million in grant funding. And most recently, he has been involved with New Jersey's contact tracing efforts, helping to develop the curriculum and launch the New Jersey Community Contact Tracer Corps. So Dr. Halkitis comes to us with an incredible background, an incredible commitment, and incredible knowledge. And while we've asked Dr. Halkitis to talk about the workforce needs of public health, it is hard to invite someone of his background to speak without asking him also to talk a little bit about where we are in this pandemic and where we might be going from here. So it is my honor to now introduce Dr. Perry N. Halkitis. Welcome, Dr. Halkitis. Thank you for being with us today.
Hey, hi, Aaron. Thank you. And thank you all for having me here. And thank you for the opportunity to address some of these issues with you. And it's been, I know, a very challenging time for everybody in this country and everybody in our world over the last year. So I've attempted in some way to put a story together here for you, which I think gets to the things that Aaron wanted, but we'll see at the end of it if I've actually achieved that. So my question is somebody moving my slides, or am I moving my slides?
I'm moving them for you.
I'm moving your slides for you, Travis.
Yeah.
You'll move my slides for me. Okay, so next slide. So I start, might look like a very odd picture for you to be looking at right now, but this is a picture of the metro in Athens, Greece. If you haven't been able to tell from my name, I am Greek. My parents were Greek immigrants. I'm a first-generation scholar. My parents came to the United States in the 1950s with a maybe 6th or 7th grade education. So my dedication to first-gen scholars is not only intellectual, but actually incredibly emotional and powerful for me. It's real. I'm so proud that I've been able to get to this point in my life. I also recognize that part of my ability to get to this point in my life is predicated on my white skin and the privilege that I've been given as a white man in their society. And so every single day of my life, never forget that and dedicate my efforts to making sure that we undo the structural racism, which is way, way too prevalent in institutions of higher education. Anyway, back to this crazy picture of the metro system in Athens. On the left-hand side, you see them trying to build the metro system. On the right-hand side, you see this metro system. And the reason I'm showing that is you see that this metro system is really, 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 really curvy, right? So when you go on it in Athens, it makes all these wild turns. And why is that? Because there was a law that was put in place during the building of the metro 20 years ago that anytime they ran into archaeological finds, they had to stop. And if the archaeological find was significant, then the train had to be detoured to go somewhere else. So what you see at the bottom is what the metro looks like now. And while it is curvy and wild and amazing to be on it, what is even more incredible is to go down into the metro station and see all these archaeological finds behind these beautiful plexiglass, displays showing the history and the culture of the Greek people over the course of the last 3,000 years. Worth a trip when we get to travel again, for those of you who haven't seen it. Next slide, please. I use that as a metaphor because to me, that is a metaphor for my life. On the left-hand side is little me, growing up in Queens, New York. On the right-hand side is big me coming to New Jersey 4 years ago. This is my 4th year as the Dean of the School of Public Health. 4 amazing, amazing years. It's been a transformative, amazing experience for me personally, but also for our school. And the reason I show you that the metro and then this squiggly line between my pictures is because I don't want anyone ever to believe, including our students at our school, that the path to where you end up in your career is always a direct path. In fact, sometimes it is a circuitous path, and often it is a circuitous path, and that is the most interesting path. I started out my career, like many children of immigrants, thinking that I was going to be a medical doctor. And so I went to Columbia and I was a pre-med and I took my MCATs and I was applying to medical school, and I decided, wait a second, that's not what I want to do. So I did what you're not supposed to do, which is like just put it all aside. I went and taught school for a little while, received a PhD in applied statistics because I love research, started doing research. And when this was all happening in the late 1980s and early 1990s, I was growing up in New York City, what was going on in Newark and in New York City at that time with the AIDS epidemic. And so around me, I was seeing death and destruction of people, and it was horrific. And I thought, I can't be this like statistician who wears a suit by day and then be an activist by night. And somehow I've got to bring these two together and I have to reconcile them. And I did. And I went and worked at GMHE, which is like the highest end of New York City, for a couple of years doing research. And then NYU found me and recruited me, and I spent 20 amazing years at NYU. But then Rutgers made me an offer I couldn't refuse. And so I came to Rutgers, and over the course of the last 4 years, my blood has turned from violet to scarlet, and it's been wild. It's been a wild, amazing experience. And the school I'm going to describe to you today, I think, is a school that speaks to everyone in New Jersey and everyone in our country, and is a school that is really trying to get people to think about health issues in a much broader perspective. I will tell you my bias right now. My bias right now is that health conditions are not just biological phenomenon. They are structural, they are social, they are political, they are behavioral, they are psychological phenomenon. If every disease was purely biological, then we would not see COVID-19 affecting African-American populations at the rate it does, or HIV. We wouldn't see obesity and addiction in certain populations and not others. And so if we're really going to train the next generation of scholars to be good healthcare providers, whether you're a nurse or a doctor or a PA or a public health person or a PT, whatever it is, you cannot just believe that people wake up one morning and want to have a disease. They do not do that. Life circumstances get them to that place. And at the School of Public Health, this is what we truly believe. Next slide, please. And so over the course of the last 2 years, we've been developing a school rooted in this notion. And I'm just going to go to the last line: engaging collaboratively with communities and populations, actively advocating for policies, programs, and services through the lens of equity and social justice. If equity and social justice drives everything that we do at the School of Public Health, and that means that we celebrate the diversity of our faculty, our staff, and our students. And by diversity, I mean the multiple identities that people hold, the intersectional identities that people hold. And we do constant work at the school to think about our own biases at the institutional level and at the personal level that may be preventing our students from moving forward. So it is a work in progress every single day. Next slide, please. And what you will see here is that my voice cracked like I was 14 years old. That's amazing. What you'll see here are the 3 pillars on which the school is built. The school that I inherited 4 years ago, I used to make this joke, I'll make it again now. I will tell you, it's a school that, if the people who were doing scholarship there could not tell you the difference between an opioid user, an obese person, and an elephant. Because they were doing public health work behind a computer. And that's not the school I wanted to run. And so the school that I have been able to build with my colleagues is a school that has 3 things that matter equally: education, doing really, really good teaching. And we constantly have people coming in to work with our faculty on teaching. You know who we do have coming in to teach our teachers how to teach? Teachers in schools, elementary schools and high schools who really know how to teach. And I say that because I was an elementary school teacher while I was doing my PhD, and that's where I got all my skills to be able to teach statistics to graduate students. I also taught Lin-Manuel Miranda, but that's a whole other story. We'll say that for another time. Number two, really cool, impactful scholarship. And this means research with and for the populations that we're studying. And last but not least, real community engagement. And this doesn't mean doing studies and going and giving pamphlets to people. This means that when AAOGC or Hyacinth or the New Jersey Department of Health calls us, we are there to engage in conversation about what the work we are doing and how we can help the people in that particular agency or in that particular part of the state. Next slide, please. And so we build a school based on the values of collaboration, creativity, diversity, engagement, equity, inclusion, integrity, measurability, performance, and respect. And I will share these slides with you so you can read them more on your own. Next slide, please. So what is public health? So somebody said to me about 2 weeks ago at a meeting, oh yeah, public health is epidemiology. And I said, hello, 1972. That is not what public health is. Public health is a social justice health equity perspective that tries to marry the delivery of care with population perspectives, right? So it is not enough to just treat a person. We have to think about the person within a population. And over the course of the last few years, from the people we've been able to bring on board, we've been able to develop areas of specialty, because students are just not like coming to you and saying, oh, I want to do public health. They're saying, I want to study nutrition, or I want to study violence, or I want to study tobacco. And so we've built expertise in a variety of different domains, everything from substance use and mental health to sexual and reproductive health. The chair of our Urban Global Public Health Department is Leslie Cantor, who is the Executive Vice President for Education at Planned Parenthood for a decade. So we've built this really cool team of people working in these areas, but again, with health equity and social justice at the basis of everything that we're doing. Next slide, please. So early in my career, everything was about HIV. The last 8 months of my life, everything has been about COVID, like nonstop COVID 24/7. And so I'm just going to do a little bit of a background on COVID and what we've been doing, so you can see the kind of work we're doing at the school as an example. Rather than telling you, I'll show you. So you all know that COVID is this virus that exists, much like HIV causes AIDS. Keep going, please. We know that there's a variety of different symptoms, but we also know that almost 50% of people don't get symptoms. So here's like the joke, right? I mean, I actually just got my COVID test back and I was negative. Woo. When I go to the gym, which I do because, you know, I'm like this like fitness nut guy, they take my temperature. And I'm like, you know, that's kind of like false security, right? Because 50% of people are never going to have a temperature. Nonetheless, I've come to understand it as a way of keeping people calm. And so these are the symptoms of COVID-19. We continue to learn about things in the that continue to exist. The development of COVID-19 long haulers is something that's fascinating to me. People who have been infected, who continue to develop like these weird abnormalities. This is an area that we all should be keeping an eye on as we move forward in training the next generation of healthcare workers. Next slide, please. So like COVID-19, like HIV, which just appeared out of the blue in the 1980s, you know, for 100 years in the 1900s, infectious diseases were going down. And then all of a sudden, here we are in the 80s, 90s, and 2000s, and we have HIV and Ebola. And so the world of public health, which had moved from infectious disease to chronic disease, has to find a space in the middle again, because infectious disease is not going anywhere. Next slide, please. So where are we today? Here's our lovely country. Alaska's way too small on this map, but that's like, you know, some kind of like prejudice in the map maker. And you'll see that the country is in many, many parts red, which is very serious. In our state, there are 840 new cases per day, and they are upticking. Whether you believe that we are in the second wave or third wave, it doesn't matter. I don't think it matters how we count. The fact of the matter is that we are headed into a very difficult time for the next few months. And why I show you this is because I think, again, as we think about how we train healthcare scholars, it is not enough in and of ourselves to just tell people, stay home and wear a mask. Yes, we should say that, but what prevents people from staying home and wearing a mask? What economic conditions prevent people from staying home? What emotional conditions prevent people from? What's going on in multi-generational homes? And these are the realities that a public health person should be thinking about. And if they're not thinking about those things, well, they're not doing their job correctly. Quite frankly, I have an article coming out that talks about the role of fear and stigma and medical mistrust with the medical community. What cost my parents their lives way too young. It is way too pervasive in all parts of our population. And we need to acknowledge that people are afraid of this disease and deal with those fears and own them. Because if we have an honest conversation, right, we will be able to hopefully tackle this a little more effectively. Next slide, please. And so what you see here then is how many deaths have happened around the world. And on the far right, you see we have about 1 million deaths from SARS-CoV-2. Now, here's what's really interesting here. That's in a year. HIV, which is all the way to the left, is 39 million deaths, but that's in 40 years. So this is a disease that is moving very, 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 very rapidly. And I just give you that as a form of context. In the brown, the one before the last, is 50 million. That was the 1918 flu. So we could very well be on track for multi-million deaths that are going to continue to happen. Next slide, please. And then when we look at here, the mortality in the United States, same pattern emerges. To date, 675,000 people have died of HIV, but 220,000 people have died of coronavirus in 9 months, 675 in 40 years. So HIV, while a horrible disease and horribly stigmatized, not as easy to transmit and not causing as many deaths at such a rapid rate. Next slide, please. Look at this. This is a comparison of USA, Italy, Greece, and the world. Why did I pick USA, Italy? Well, USA, we lived there. Italy, because it was an epicenter. Greece, because, I'm a proud Greek. And the world, because, we have a common metric here. What you see here are the deaths per 100,000 and the cases per 100,000. And what you see really consistently is that the United States far surpasses the world and other countries in terms of cases and in terms of deaths, despite the fact that we knew. Look at Greece. I use Greece as a perfect example because here's a country that's had economic hell for 12 years, yet they've only had 5 deaths per 100,000. We've had 67 deaths, one of the richest countries in the world. And Italy somehow managed to be less than us at 61 deaths per 100,000, despite the fact that they got hit before us. Next slide, please. And why is that? It's because the Greeks shut things down, right? And the Greek government moved really quickly. And that's the model we've been using to inform the work we've been doing at the School of Public Health. Next slide, please. By trusting experts, by being efficient and speedy, by being transparent, clear, and enforcing communication, by strengthening the public health infrastructure, by thinking about the society as a whole, and by defying cultural norms. What I will say is that why I shared this with you is because the curriculum we have developed to develop the contact tracers, we've had the great fortune of having the chance to do for the state was possible, was informed in a great part by these ideals that exist here, right? So what I say always on interviews, often from this seat in my lovely home in Newark, is the following. If wearing a mask is such a problem for you, then what I want you to do is think about the most vulnerable person in your life. For me, it's my brother who's living with MS, and I wear the mask for him. That's what we need to tell people, and that should be our commitment because altruism is going to save us ultimately. Next slide, please. And so as we've developed this program at Rutgers, we've developed a program that rests on what I call 4 T's: targeting, identifying communities that are most at risk and testing them, because not everybody is at equal risk, Just like for HIV, not everybody's at equal risk. Some populations are more at risk, and we should be making testing easier for those populations. Then treating people as much as possible, which includes quarantining, and then tracing. Contact tracing is going to be really critical. The state, we're having some challenges in our state, we're having some challenges in our nation with contact tracing, but finding out who people could have infected is really, really key. And again, it's not about tracing the person, but it's about potentially finding people who might have much worse effects from the disease than the person who's infected themselves. Next slide, please. And so we have a bunch of different tests available, as you all know, including PCR testing, which is the swab in the nose, which is the virus. And then we have antibody testing, which tests if you've had presence of the virus. Now, shockingly, there's this anomaly here because I had this really weird cold for 4 days in March at the beginning of it. I tested for antibodies. I mean, I just thought I had a cold. I was like, whatever, I have a cold. I'm going to stay in bed for 4 days, right? If I hadn't known there was COVID, I would have gone to the gym, right? But I didn't go to the gym. So I stayed home. In May, I had antibodies, and as of yesterday, I still have antibodies, which is really wild to me that I still have these antibodies for it. I don't know if they're doing me any good, but I'm going to make believe they're doing me some good. And then what's really, really, really developing quickly is the antigen test. And this is the quick test in 20 minutes. The state is going to start to distribute it widely. We need our students. We need healthcare providers. We need community college students. We need students in vocational high schools to begin to understand these concepts so that they can become the workforce that works with and for the people of New Jersey. I have often said we need a healthcare workforce, public health, doctors, nurses, that looks like the population. If it doesn't look like the population, we're not doing our job right here. Next slide, please. So contact tracing, again, it says it has a long strategy. We can move past the slide. Here, we have brought together the efforts of government and the Department of Health and higher education, because we often live in silos. And this is why I'm here with you this morning, because I believe we as a school of public health and we as a university have a moral obligation, a real obligation to prepare students who are entering the world through the vocational and the community college track. I started my career at NYU, where I was in the applied psychology department, where the CC Top program, the community college program, brought us some of the best students I've ever worked with in my life. And those are the students who worked in my lab and who have gone on to make amazing careers for themselves. We need to do the same thing here. And I have committed myself to Aaron to figure out how we as a university can make that happen efficiently so that it's parsimonious in terms of time, but also parsimonious in terms of cost. Nobody should have to go get a bachelor's and then go get a master's. Why not combine those two? Why can't we go from the AA to the BA to the MPH in a protracted amount of time that makes it easier for the students to actually complete their degrees? And that's what I'm committed to figuring out with all of you. Next slide, please. The curriculum is amazing. It's 18 hours long. Like many of the things we've developed at the school, it's fully online. It's asynchronous. So when I got to the school, we had some online courses that felt like 1992 AOL dial-up, quite frankly. We've updated those. They're now much more modern. And we actually, by developing these courses, we're able to do something really amazing. We were able to offer the curriculum of our public health certificate to people who are working in the Newark Department of Health at near zero cost. So instead of having to spend $12,000, they can spend $2,000 and they can do these courses online at their own speed. And that is our commitment to the community. I'm going to keep going because I know I'm running out of time here. Next slide, please. So we ended up hiring and deploying 900 tracers that went out into the world all over the state. Next slide, please. And again, because we are completely committed and live every day the idea of diversity, equity, and inclusion, made sure that the workforce we developed also was reflective of the diversity of the state. Because quite frankly, somebody from Cumberland County knows Cumberland County. Somebody from Essex County knows Essex County. And we tried to train people who went back to their counties. Next slide, please. So what the future holds, we all know that we're up for a challenge the next few months. We're going to just have to hunker down here for a little bit longer, like in our homes. And really, people, I don't know what's happening with Thanksgiving this year, but I wouldn't count on it. But hunker down to protect the people who we have to protect. Next slide, please. I'm going to finally end, I think, with this is my final slide here, which is this is an urban public health paradigm that Leslie Cantor and I have developed. And again, the notion here is that social justice and health equity are the umbrellas that define everything. But clinical care, medical care, and public health often fall short. And they often fall short in that clinical care thinks too often about the people and their behaviors, and public health thinks too often about populations and policies. And there's a truth that exists somewhere in between that, right? And that's what I call public health psychology, the recognition that loneliness and stigma and fear are the reason my father avoided doctor till it was too late, or my mother avoided the doctors. We have to address those things better. How do we address those things better? By bringing together the academic health care system with city governments, with people like the Newark Department of Health and my friend Nashon at the New Jersey Department of Health, with the community, of course, because the community knows what it needs. Like they know, you just have to talk to them. And last but not least, with industry. Like the industry folks, the Audible folks, the Amazon folks, they know how to do business. So if we can bring to the table these four constituents, and this is something that Leslie and I are building for our school, we will be able to enact a public health program that is modern and real and relevant. Next slide, please. And so there I am. You can follow me on the Twitters or on the internets or on wherever else you can find me. It's been a pleasure being with you this morning. Thank you very much for the opportunity.
Wow, Dean Halkitis, thank you so much for being with us, and thank you for your observations and thoughts. One of the folks in the chat said that you are one of their favorite public health giants, and I think you're one of my favorite public health giants as well. I think all of us really appreciate your leadership, all of your comments. See a lot of claps online. So thank you, Dean Halkitis. We look forward to working with you in the months ahead. We will get through this pandemic and we will build a more equitable approach to public health if we do it together. So thank you very much.
My honor.
Working
Totally
with
my
you and
honor,
your
Aaron.
incredible team at Rutgers. So thank you very much.